we're going to introduce our bias of translation to create the side bending. Very simply though, just as a review, what happens to the occiput when we go into extension? Which way do the condyles glide?
Anterior.
Anterior. If we side bend right, which way does the rotation happen? Goes left. Very good. And with a bias in extension, where do we expect to see the problematic condyle? On the same side as the side bend, correct? Because that's the only condyle that's going forward when we do the side bending. The other one is going posterior. That's that word essa that we talked about, that little mnemonic essa. So going into extension and side bending, the problematic condyle is on the same side because it can't go anterior. Right? Good. So if in the position, and I have the model, and I think this will work better if I do it a little more of that. Okay. This is nice though, it's got the arms. Can't wait to go to town on this thing. It's like holding on to handlebars and riding down the street. I like it. So, you're going here. You're going to bias the occiput in some extension, just a slight bit. So we also don't want to cause problems with what? We don't want to be problematic with what major thing runs through that area, vertebral artery. We don't want to include that. And those are things that we should give consideration to when we're doing our manual therapy techniques, especially in the upper cervical spine. The 5 Ds, remember those? Dizziness, diplopia, dysarthria, dysphagia, and drop attacks. I'll say them again if you'd like me to. Dizziness, diplopia, double vision, dysarthria, difficulty speaking, dysphagia, difficulty swallowing, and drop attacks, where suddenly the person is walking and boom, they drop down to the floor. It's not like they're passing out or getting woozy, they just drop down. And we had the 3 N's that you learned in manual therapy too. And those were nausea, nystagmus, and numbness of the perioral region. So right around the lips. And then we had the A that you learned, which was ataxia. So if you have somebody walking into your clinic and they're presenting with all of these or even some of these, it's no good. So refer them out to the physician or send them back to the physician. And maybe err to the side of caution of not beginning your treatment at that point. Make sure they go through a barrage of time. Would you send it to the emergency room? You could, either to their physician or to the emergency room. Absolutely. And then document that. Document that that was your approach, because documentation is important. If it was never written, it never happened. Your risk management officer at your hospital will be very happy I told you that. Document everything, and it's important for that because should they need to review the case, there's something there. It could help the person who the argument is against. It could help the argument for the person that the argument is for. But if there's documentation there with everything, not just this, it's going to be very helpful to your career. You may need to look at that file someday 7 years after you saw the person. And if you just had evaluate and treat, treatment as before, treatment as prior, and that's how you did it, good luck at objectifying what you were doing during those treatments. So don't do that. All right, so I go back to where we started. Sorry about that. So we're going to bias the occiput in a little bit of extension. Okay? We're going to add a little side tilting to the right. Which way is now the rotation occurring if I'm side bending to the right? Left. So now I'm assessing the ability for the condyle to, on the right, go anteriorly. I now go back to neutral and I start it again. I'm supporting the occiput. Now I'm going to side bend to the left, which then is causing rotation in which direction? To the right. And because it's on the same side of the side bending, I'm now stressing the condyle on the left to check its ability to go anterior. Because in that biased extension position, that's the only condyle that can go anterior with the extension motion. Right? And I'm assessing left to right. If I assess right to left and cause the right side bending to occur with the left rotation, and I find that it's limited, my diagnosis then is going to be a lesion that is flexed, and if it can't side bend right, which way is it side bent? Left. And if it's side bent left, then it can't rotate right. So that's my clinical diagnosis of OA. It's flexed, side bent left, rotated right, restricting me from moving into extension, side bending right, rotating left. Right? Let's walk through that one more time. So I want you to be crystal clear, but I saw a lot of people already mouthing the words before I even said it. I'm in extension. I side bend to the right. Which way is the rotation going? Left. I find that that's more restrictive in motion than when I did it to the other direction of side bend. Okay, so I've already compared the two sides. I found that in extension of OA, side bending right, rotation left is more restricted. So to determine where the problem is, or to give the diagnosis, we can say that that segment is flexed, side bent left, rotated right. And can you see how that rotation right really drives the point home? If it's rotated right, the right side can't rotate left when I ask it to side bend to the right. Trust me, it's confusing. I know that that is the case, especially when you can't really see it happening visually. But if you walk through the osteokinematics step by step and just reverse what your findings were on the restriction, you'll be able to come up with your diagnosis and then subsequently choose the right treatment for your clinical diagnosis. All right? Eric.
When you do an assessment, are you coupling all the motions, or you break it down motion by motion, like you were clinic? You couple it, or
Coupling.
Yeah.
All about coupling.
Yeah. I mean, it's a little faster to do when you couple the motions. There's no trouble if you want to get started with implementing first the extension and the side bending, but eventually you'll see that once you get the feel for it maybe one or two times, that you'll go right into the coupling motion, because it works that way, it just happens that way. You don't have to separate the side bending and rotation because those are happening simultaneously. But the lead up from the extension to the side bending rotation, you can start with the extension first.
Just to be clarified, so for the example, if we side bend right, we rotate left, right?
Mm-hmm.
And you're
Go ahead.
in the extension bias.
Yep.
So are you talking about the restriction is they stop in flexion, side bend, lateral direct, or they cannot go into that route?
What I was describing was that they can't go into the direction, because when I assess extension, side bend, rotation, side bend right, rotation left, there's a limitation.
I think that are you asking, is the diagnosis the position or the motion loss?
The motion loss.
The
You're
motion,
assessing the motion loss, but when
That's-
you write it down, you're going to write it down as the position it's stuck in.
so in that particular example, what are you going to write down in that particular example?
what I'm gonna write down in my example is the opposite of the motion restriction. If I found restrictive movement into extension, side bending right, rotation left, I have to positionally diagnose it as flexed, side bent left, rotated right.